No.
Who's going to start us off?
Karen, you're going to go ahead and start us off?
Yes, I can start. Lisa, can I have, is Steve not on the line?
Yeah, he is.
Okay. Lisa, can I have control to share our PowerPoint?
You don't have a share screen button on your...
Hold on just a moment. All right.
Yeah.
Okay. All right. Can everyone see my screen?
Yes.
Okay. So Steve is going to start us out, but this is a presentation of our OU Parent Partnership Advisory Committee. Steve?
Yes. Hello, I'm Steve Ross. I am the Safe Care Program Coordinator for our Safe Care Prevention sites. And this afternoon, thank you for letting us come and share with you about the OU Parent Partnership Advisory Committee. And we're excited in the past few years, we've had a Safe Care Parent Partnership Advisory Committee, and we are going through a transition and wanting to include families involved in the PAT program and the C1 program. So the Parent Partnership Advisory Committee helps families build a strong and vibrant parent community through empowering family voice and advocacy. And you can go to the next slide, Karen. Like I said, we have been working and operating continuously for over 10 years. And we want to thank all of our community partners that have helped make PPAC happen. So the Potts Family Foundation, Safe Care Team at North Care, Parent Pro website, the Oklahoma Institute for Child Advocacy, the University of Oklahoma Health Sciences Center, St. Luke's United Methodist Church, and EB Enterprises, LLC. So just a little bit about our vision. The OU PPAC actively collaborates to bring family voice and experiences to state and local agencies to enhance how these agencies support families with young children, to raise them to be healthy, well-adjusted, and ready for school. So we strive to support those families and community in raising healthy, happy children. We resolve to reflect on, develop, and adopt practices and policies that are inclusive and promote equity in all of our work. So you will play a really important role in this in helping us recruit families that are diverse and reflect the different needs that our families face with young children.
Okay, thank you, Steve. And so the section that I'll be covering is the family engagement and community partnership section. So just to piggyback off of what Steve was talking about, the purpose behind our collaboration and why it's important for us to infuse family voice within the processes that we do in research. And so I'll just cover that briefly, and then LaShonda will close us out. So the problem as have been researched, as you know, studies have shown that the problem is that the child welfare system continue to disproportionately intervene in families living in poverty and families of color, who generally have little power or voice in a system that affects them in the most intimate aspects of their lives. And this is according to the State of Oklahoma Prevention Resource Guide from 2021. And because of this, their participation within the systems, they often lend themselves to added trauma instead of healing. So the solution, and that's where we come in, to embrace family engagement and community partnerships. The solution is for Oklahoma to improve efforts that are aimed at reducing adversity and enhancing health and well-being. So our OU Parent Partnership members, we help to enhance engagement and retention. So the goal with the Parent Partnership Advisory Committee, we seek to incorporate the family voice within the research process. So members of the Parent Partnership Advisory Committee, they will review the recruitment materials, research measures that we're using, and they will assist with the evaluation findings. thereby exploring health equity through parent voice in family engagement. So our plan model. The Parent Advisory Committee highlights the spaces where child abuse prevention and family support agencies interact and engage with communities that we serve. And for anyone who's familiar with models, that resembles the social ecological model. That our theory, the theory that it closely connects with is the self-determination theory. So the need for growth drives behaviors. The internal motivation of the parents to make meaningful community engagement a priority will fuel an environment that lends itself to transformative change. Best practices. So there has been family engagement programs that have been implemented throughout the communities. So there are identified things that we can do to help improve the engagement piece of those programs. So within our parent partnership advisory committee, we will seek and have done several steps to enhance the level of family engagement from or in with our parents and the programs that they assist with. So step one, addressing demographic denial. Step two, responding with mutual accountability. Step three, implementing technology, developing 50-50 partnerships, addressing individualistic interventions, and compensating our community experts. Again, we will use our RedCap platform to capture surveys. I have an example of a survey that we would like to co-design with you, our home visiting leaders and staff members with our parents. So we are creating we're creating surveys to gauge their engagement, but we will do that through co-design. One of the measures that I found that would be interesting for us to look over during our first meeting came from the Health Resource and Service Administration. Many of you are familiar with HRSA. And I pulled out one question. Can you all hear me? Hello?
Yes, we can hear you.
Yep.
Okay. So I've lost connection. However, LaShonda, if you're able to pull up the slides on your end, I just sent you. I lost connection, but that measure, if you all are able to see it.
We can.
You can see it, okay. So there's some wording in there that allows us the ability, it's flexible, so we can come up with the questions that are tailor made to our program and what the home visitors and the families will decide on together. LaShonda, were you able to pull up the presentation and take over the screen?
Just a minute.
While
Okay.
you're doing that, Purin and LaShonda, let me interject just briefly for the folks, because I'm not sure that we've had a complete comprehensive discussion yet on the impact of PPAC in evaluations that's forthcoming. And my apologies for not jumping in sooner to provide that preface. The MCFE funding that we're all very familiar with at this stage does provide dollars for evaluation and research. And in the next phase of this, I think requiring is the appropriate word to use, requiring that we incorporate even more parenting voice in our evaluation and research activities than we have in the past. We've been very fortunate to have PPAC around and to evaluate, for instance, our research questions and some of our materials like surveys that we've used in the past. We will continue to do that, but we're doubling down on that effort. And there'll be a variety of ways that we'd like parents to be more involved in evaluation and CQI activities. including revisiting techniques we've used before, like having parents from the advisory committee and from your programs participate in future learning sessions. And so we will be asking programs to recruit a family representative for the PDSAs that are developed in January's learning session. And leading up to that point, you're going to hear more from our PPAC group on advice for recruiting families to that event, but also ways that they foresee having an impact or having an effective impact on our referral processes, the focus of that particular CQI collaborative. The research and evaluation activities that our group has been doing now for several years will continue, and we'll be leaning heavily on PPAC for advice on what our surveys look like with your clients. We certainly welcome agency input on that, and we will be providing you feedback as we go so that you can see what types of measures we are presenting to the clients, and also what the ultimate aims of those measures are. Kieran just hinted at health equity. That is also an underlying theme and requirement of forthcoming MCV evaluations. And so that's sort of the umbrella of all things we intend to do in evaluation and research over the next couple of years. And one of the areas that we're looking at PPAC to help guide us on how we best understand what that term means, and also how we measure it. So a lot forthcoming today, and this is just a brief intro to the advancements that PPAC has made over the last several years, and to give you just a taste of what's to come. So how are we doing on the technical issues, LaShonda or Pierre?
Yes, I'm back up. Thank you
Back.
so much,
Okay,
Dr.
great.
Bart, for the clarification. Thank you. Okay, LaShonda's up next, and she will go over what's next.
So Karen, were you able to launch the PowerPoint? Or
Yes,
send it over?
can you not see it?
No, I don't see it. Is it? Can you
Yeah,
guys-
you're not
Okay,
sharing yet.
Okay, yeah, you have to read.
Okay, let me go back in and reshare here. Thank you all so much for your patience too. Hold on just a moment. Okay, got it.
And so while Pierre is doing that, I'll just go ahead and talk a little bit. So I want to first start off by saying thank you. Some of our PPAC members actually are tuning in today, and we're so thankful to have them join us. We have quite a few people in here. A few of the names that I saw was Lubov, CC Grant, Miss Betty Hawkins is on here. And then a team, PPAC team, if there's anybody else I missed, just shoot it to me in a text and I'll make sure I mention that. But I wanted to highlight them and say thank you for taking time out of their day, coming in the middle of the afternoon to be here as hey, Lubov. And then also I want to thank our amazing team. Caitlin Owen is here, and I believe Curtis is on here. And we have several team members over here that help drive this, this amazing committee going forward. But I wanted to first say that. Another thing I want to say, as we're talking today, and Dr. Bart kind of hit at that, is right now we're still in the planning period. And that's important. So as we're talking, we're not saying, exactly everything we're going to be doing. We're going to figure this out. And one of the main ways we're going to figure that out is by having the current PPAC members there in the planning process with us and building this up. So we're going to expand the PPAC because traditionally it's been just Safe Care. And now we're going to do all the Parent Pro programs. So we want to have representation for Children's First, Parents as Teachers, and Safe Care. Just so you guys know about that. Next slide, Karen. So, what does this look like? It's made up. So the important key parts is the parents, right? Parents that are participating or have utilized a Parent Pro program with you, home visitors. home visitor leadership, and then also probably your agency is also a part of that. And it's all of us coming together and sharing together, co-leading, learning, developing together is where the magic happens. So everybody is a very important part of this. You can go ahead and go to the next slide. So just to kind of paint the picture for you a little bit. So between now and December, we're in the planning stage where we will be building more structure into what it will look like. And between this afternoon and probably toward the end of August, where our ask of you is going to be that maybe you share our application with families you have served. And so right now what we're looking at are families that have used the service in the last 18 months or are currently using services. They do not have to have completed all the services. We want very diverse. So we can try to figure out why do some families engage longer than others, and what does it look like in different parts of our state, and what does it look like for different groups and things like that. So so for the next month or two, we want to try to see if you guys can circulate that around to families. And so we'll start the process of trying to go through that and recruit families. We'll be working to develop some of the quantitative and qualitative measures and things. We'll be, once we go through that recruitment, we're going to try to expand to up to 12 parent leaders, parent advisors. You'll hear us kind of in exchange those. We're going to try to expand it. Our goal is to get up to, by January, to have 12 parents that are participating in become part of the PPAC. So some of our parents that are still here, they're the experienced parents that are here that are going to join and welcome in new members and kind of walk it out with us. And they're going to also be able to provide that parent voice going forward. So every step of the way, they're going to be providing guidance and input on what that looks like. Just so you guys can kind of see that. And then what is it going to look like doing the CQI and all that? Your voice is important. Dr. Barr to be steering, and we'll be steering that and seeing what does that look like? How can we get parents' voice? We're going to be looking at all the different ways of how can we increase parent voice. Is that through some can attend live during the session? Is it watch videos afterwards, or what? We're going to be exploring and have them inform us what works for families, what will fit with that. And traditionally our parent advisory committee has consisted of, we have a father figure group, we have a mom's group, and then when we meet, we provide childcare and the children meet. So really it's several groups. And so we're trying to take this model that we've used for over 10 years, weave it into the study and bring it together and see how that works. So, it's not, there may be some adjusting, but again, stressing by bringing everybody's voice coming together, that's where we're going to really have a huge impact on improving family engagement and impacting families across the state of Oklahoma. So we're super excited about that. So our goal is to go through all the planning. January hit, bam, and we'll be hopefully up and running. Everything on here we're talking about today is tentative. So those are some of the milestones and things that we're hoping to get through. But just want to ask you guys to be patient with us. We want to say we're looking forward to this journey, learning from you and you guys learning from us. And we'll, continue to figure it out as we go. So we have a letter flyer that we will be dropping into the chat box. There's a QR code and there's a link where you can share this with your families, and it tells them a little bit about the qualifications for being in the PPAC that we'll be asking you to circulate. We're hoping that you'll circulate to lots of people, because as we go through, we really want a very diverse group. And so we're going to need large numbers to go through that. So that's our big ask of you. And then just to share something else. So if you're like, hey, it's great that we're going to be able to work with parents doing CQI and all that, but hey, we need our own group that we can have access to back at our agency. Great, we have something for that too. We've developed a training for developing and sustaining a productive parent advisory committee. We have a QR code here as well. And it's going to be launching in the fall. And it's going to be a cohort or up to 30 agencies and organizations. So if you want information about that, you can also go to that QR code and fill out an interest form, just saying like, hey, I would like to get more information on that. What does that look like? And I think that's all I have. Does anybody have any questions? So again, just to thank our current parent advisors that are going to walk through this planning period and then help us train new members that will join. Our current members are Tiana Hawkins, Lou Bulk Beckner, Miss Betty Hawkins Embry, CC Saterica, she goes by CC Grant. We have Michael Emmerich, Stephen, should have asked them how to say their name, and Blake Beckner. So we have 3 fathers right now, 4 mothers, and they have all their family has interacted with the Safe Care Parenting model.
Thank you, Purin, LaShonda, and Steve. So just a quick recap. PPAC is expanding its roster, and they would like representatives from some of these other programs, in addition to the Safe Care clients who already participate. So we'll be in touch about getting you the brochure that LaShonda just demoed so that you can put those in the hands of interested clients. And then, as I said, in forthcoming monthly calls and in our usual interactions, we will provide you additional information on how PPAC is advising the next phase of our evaluation and research. As I mentioned at the learning session that we will host in January, when we transition to the Unite Us and the two-way communication referral learning collaborative, we would like parents to participate in the creation of PDSAs. Today, we are thrilled to have some of the PPAC members join us so that they can get an inside look at what development of PDSAs is all about. So don't be surprised if during your breakout session, a new member joins, one of our PPAC members or one of the leadership folks here from the university who are involved in PPAC sit in on your PDSA development breakout to get a sense of how parents can be contributing to the work that's ahead. And Lisa, I'm not sure if we've got that coordinated yet or not, but I would try to distribute them as broadly and widely as we can so that they can get a sense of all the various programs who are participating in the collaborative. Before we move on to another topic, any questions about PPAC in general or PPAC's involvement in the home visiting activities ahead?
We might want Lisa Tunley to distribute the handout that was supposed to be dropped into the chat, and maybe the link that was associated with that QR code. So if LaShonda or Purin could send that to Lisa Tunley, we can be sure everybody gets it. And then in your own time, you'll have a chance to read more and learn a little bit more about this and think about families who may be interested in getting involved.
Yes, we'll send that to Lisa.
And I
Thank
saw
you.
the thumbs up from Lisa, so she'll get that distributed right away.
I guess I have I don't know if it's a question or a comment. Usually trying to recruit non-English speakers is very difficult. Of course, you can't present that kind of flyer without being in Spanish. And even if it's in Spanish, like in PAT, we're required to have our advisory council. And like, I'm just going to give an example. Every member that we have in our team, they speak Spanish, and it still is intimidating for parents. So that I would like to hear more of how those parents feel like how they were able to cross that boundary, but imagine even a language barrier. So even when we have ours and we get a great input with parents, but we struggle even just to keep them. And even though everyone speaks Spanish and they feel comfortable, I can imagine mixing a group, and then you'll have to have a different kind of process for those that do not speak the language. That could be super intimidating.
I'd like to address that question. Again, my name is Betty Hawkins Emery, and I've been a part of this group, I imagine, since its inception. And throughout the years that we have had the parent support group that was originally Safe Care group, we had a diverse group of parents, fathers and mothers, and some were Latino or Hispanic speaking parents, but they were bilingual. We had never had a problem with it. It was always engaged because, as we talked about and kind of went over before, the parents are given an incentive to come there. We offer something for transportation or their time to be there at the support group. Of course, this is a new group. This is a PAC group. We haven't worked everything out, but those are the kinds of things that we offered to keep the parents engaged. We offered dinner, evening meal for the kids, and also childcare. You know, it is important that all of the family, father, mother, and children, all the siblings, is engaged and are excited or even interested in what's happening with them. My son is a special needs child. He has Down syndrome, and he enjoys coming together with the kids, even on Zoom meetings and at their children's group. I don't see that has ever been a problem. I don't know if it would be a problem. I'm expecting that it wouldn't.
Thank you, Miss Betty. That's wonderful to hear that you've had some experience with bilingual parents participating previously. LaShonda, do we have any plans for recruiting?
Yeah, so we haven't started developing our Spanish application stuff. We do want Spanish speaking families. We want it very diverse, and we're just it's a living, it's like a family, a living organism. And we try to, the main thing we do, and relating back to what Patty was talking about, is we really try to early on establish relationships, find out what our family's barriers are, and empower them. We always say, this is your group. And I know a lot of people, you guys probably all do that too, but by sticking with empowering the parents, letting them know it's their group, finding out if there's certain barriers and things, and then try to come up with ways to work around that. So everybody's coming kind of like with the same goal. And it's through those intimate connections that seems to kind of glue the group together. So we want people that English is not their first language, and we're trying to figure out how to work that out. We're gonna figure out, that's a goal, is to have representation in there, and we'll see. And again, just to prepare you guys that, hey, we'll try to, if we run into a problem or a challenge, we'll try to see what can we do to work around that. Before, when we had a family member that spoke Spanish, sometimes she would bring another family member, and she felt, more comfortable that way. It is a little bit different when, because we had a very intimate connection with Safe Care and being over at North Care. And so that relationship is kind of there, bringing over. So it kind of gave us an advantage. But we're gonna see how that works. And we want to get those parents in there and be like, hey, tell us what you think, what's working, what's not working, what didn't you like, and be transparent. and empower them. And hopefully we can, then based on what we learn, hopefully we can go in and share that with other groups across the state to serve families that maybe English is their second language. Excellent question. And we'll be calling on you, Patty, because we all we're trying to get families from, all across the state. So someone's not going to drive in, come in from, Tulsa even, and we have places further than that. So we're looking at how to provide a hybrid model. And then the other deals we're really going to be asking the parents is like, how often, can you meet and what's best? So they want to, one thing that the parents, we spoke last month at our monthly meeting, they feel that having their monthly meeting and do that and be involved in how that, but not taking it up. So going to be
It sounds like really valuable input that we can get, and I think paying attention to the feedback from and the advice from these stakeholders is crucial to really getting a good service being provided. So thank you for doing that.
Yeah, I'll reiterate, we appreciate your involvement both historically and then now, this strengthened partnership that we'll engage on together in the months and years ahead. So thank you. And again, more to come, home visiting folks from PPAC and from our group on how this all shakes out.
Okay. You're seeing the there we go. So you should be able to see my presentation now.
Yep.
Okay, great. All right, so I'm going to talk a little bit for a review of PDSAs, because when we were having our prep meetings with each of the programs over the last month, I learned that there are some people who have been moved into some leadership positions who hadn't been involved with the development of a PDSA. And I know the first time that I attended a meeting without very little experience with PDSAs, I was kind of lost in the planning meeting, and I was supposed to be the analyst helping. And I remember getting on my email and emailing Helen and saying, Helen, can you come into this breakout room? I don't know what I'm doing. So I thought we would do just a little bit of a review, and we'll start with a short video. Then I'm going to give you an analogy using a Fitbit for explaining the change theory and the difference between outcomes, processes, and disruptors, and the measures of outcomes, the measure of process, the measure of disruptors. So let me see if I may have to stop sharing and reshare. And I'll stop the video real quick. It probably is going to have an ad to start. It's thinking about it. It's saying, you're sure using a lot of resources. Yes, I know my browser's up to date. Okay, just a second.
There's no audio, Lisa.
There's no audio.
Mhm.
Darn. I can hear it just fine. So that's, does anybody know how to fix that? Maybe,
When you share the video, you have to go to also the, you say share with sound. And that will be the only way.
oh, okay.
Once you share, Lisa, I think it's an option in the menu.
I see it. I see it. I got it.
Hi, I'm Dr. Mike Evans, and today's talk is on
You hear that now?
quality improvement, or QI, in health.
Okay.
So I suppose the first question is, why should you or I care about quality improvement? I mean, to be honest, it sounds a bit boring. Something a CEO would have on her or his corporate objectives. But actually, if you dig a little deeper, it's pretty cool. Maybe more of a philosophy or an attitude about how to make something better. And now that I think about it, it's really the attitude I'm looking for in my patients. The ability and desire to tweak their habits, seeing if this change improves their life, and if it does, to try and make it standard practice. You see, for my patients to make these changes requires skills, but it's also an outlook. The humility and self-awareness to say, I've got room for improvement. The ability to gather better approaches, try them on and see if they work, and then adapt them until they do. Well, if my patients can do that, I think they deserve the same from us in the healthcare business. So I suppose the next question is, if we have the attitude, how do we actually improve? How do we use QI to make care better? Well, the improvement business has been around for a while. Organizations like Toyota and Bell Labs and leaders like Walter Shewart, W. Edwards Deming, and Joseph Juran polished and simplified the science of improvement. And then along came a pediatrician named Don Berwick, and he wondered if we could translate the science of building better cars or electronics to healthcare. Dr. Berwick also wondered if there were lessons about systems we could learn from the kids he saw in his clinic.
The systems thinker is a perpetually curious person who never thinks they have the whole answer, but is always willing to know what the next step to take is. If you watch a child, you'll see this happen. Children in their growth and development are innately systems thinkers. They're always trying the next thing. They're probing the material. They're listening to the noise. They're thinking about what the next thing to do is, and they're not in the job of solving problems forever. They're in the job of taking the next step. I think those are elements of what it means to be a system thinker. At the core of it is constant curiosity about a world that you will never understand fully, but you might take the next step to understand a little better.
Okay, we've never dropped a vid into our vids, and Don is thoughtful, so I kind of thought it might improve our messaging. Let me know if you thought it did or didn't in our YouTube comments. Now, Dr. Berwick went on to co-found the Institute for Healthcare Improvement, or the IHI, and started focusing on the low-hanging healthcare improvement fruit, which is mostly reducing errors. For example, in Canada, a researcher named Ross Baker led a study in 2004 that showed of 2.5 million annual hospital admissions, about 13.5% were having adverse events, with 1 in 5 of those people dying or experiencing a permanent disability. In the US, the Institute of Medicine estimated that 44 to 98,000 people were dying from preventable errors every year. That's up to 4 jumbo jet crashes per week. Often these are errors we know how to prevent, but as is often the case, knowing what's the right thing to do and actually doing it are two different things. In 2006, Berwick and his colleagues challenged hundreds of U.S. hospitals to bridge this gap and felt strongly that some is not a number and soon is not a time, and so set the goal of saving 100,000 lives in 18 months. They started with this simple notion: every system is perfectly designed to get the results it gets. So how do you change the result? Well, you change the system that produces it. Changing the system requires change agents, and in my province we launched Health Quality Ontario. HQO and orgs like it recognize that it's tough to balance proactive and reactive care in the field. But if they can help or incentivize or nudge us towards a more reflective practice and improve outcomes, we can actually create a better user experience for us all. Now, making this sound simple, like pushing a button, but getting people to change, even a simple behavior like hand washing, can be very complex and exasperating. But these seemingly small behaviors can have a ripple effect on health. A 2010 study calculated inadequate hand washing caused 247 deaths each day from preventable hospital infections, and that's just in the US. So let's jump back to simplicity. How to improve seems to boil down to 3 questions in a cycle. Improvement starts by setting an aim. So question number 1 is, what are you going to improve and by how much? So for example, we are going to get 70% of the staff to wash their hands before and after seeing patients by December 1st. Great. We have an aim. So let's start testing some changes, okay? Not so fast. Now you need to ask question 2. How will you know if a change is an improvement? We need to choose some things and measure them. What is doable and reliable? And that will tell us if the changes we are making are leading to an improvement. Is someone documenting doctor or nurse hand washing? Is it self-report? Is it the amount of soap and disinfectant used? Okay, we have an aim and now we have some measures. Next up is question 3. What changes can you make that will lead to the improvement? To start, we just want to test one change with something called a PDSA cycle. Plan the test, do the test, study the test results, and then act based on those results. Maybe it's new soap dispensers or little bottles of gel. Maybe you read about the study that changed the signage from wash your hands to protect yourself to wash your hands to protect your patients, which resulted in a 3rd improvement over a 2-week period. Maybe it's reward or audit and feedback or asking patients to check. Just pick one and get started. Then you test other changes and the PDSAs just keep rolling. Fine-tuning the change based on what you're learning. Saying to yourself, here are some ways we can improve. Let's try them out by dropping them into our practice in a thoughtful way that fits with our clinic and our patients. And let's measure how we do. Adapt, adopt, or discard. Simple, right? But powerful, and it actually works. At my hospital, St. Michael's in Toronto, elderly patients with fractured hips were often waiting more than 2 days for surgery. This wait was painful, with increased chances of conditions like delirium and depression, longer recovery times, and even death. The care team scratched their chins, mapped out and redesigned every step of the journey to surgery in order to fast-track these patients. They created a code HIP called as soon as the patient arrives. This streamlined them to the urgent list for surgery, rapid triage, essential testing, priority consults from anesthesia and internal medicine, and so on. All these tweaks led to a jump from 66 to over 90% having surgery within 48 hours. Now, these changes don't happen without engaging the human side of change. One thing you'll discover is that it's possible that the people you work with might not be as into hand washing or urine infections or diabetes as you are. I know, crazy, but this leads to 3 pieces of advice. First is the concept of innovation fatigue. Often your workmates are getting overloaded with requests for practice change, which are well-intentioned but can be overwhelming. My own approach is to take a page from motivational interviewing. MI recognizes some of our natural inclination as problem solvers is to fix things, provide advice, and argue for change. But the reality is that not everybody is ready for change. Both MI and QI recognize that ambivalence about change is normal, that building readiness and confidence for change, a shared agenda, requires careful listening and strategic questioning, the ability to roll with resistance, more of a dance than a directive, I would say. Actually, sometimes resistance to change can actually be an opportunity in QI. Creating diversity or disruption can actually be an opportunity, something to build on. My second point is about priorities. I think we have to acknowledge that patients and your fellow clinicians may have certain priorities on the day. That talking about depression or headaches may trump your diabetes flow sheet, or even that focusing on their non-diabetes issue might in fact be more helpful for patient self-management. These shifting sands, the transition from silo care, are the reality of the emerging science of complex care. Sure, asking what's the matter, but also asking what matters to you. A great example is in Timmins, a small town in rural Ontario, where they wondered if they could do a better job of handling complex patients in the emergency department. So people seen in the emergency more than 14 times or admitted more than 3 times a year. They started with standard assessment tools, identified diagnoses and related problems, generated care plans, but unfortunately, patient use didn't decrease. The team then flipped their approach to what's called patient discovery, where they identified health and lifestyle challenges from the patient's perspective and combined that discovery with motivational interviewing techniques. This new patient-centered approach resulted in more than an 80% reduction in emergency room use and admissions. Finally, after having done many interventions, my mantra is, how can I make it easier to do the right thing? Maybe easier is about sharing the load. At Kaiser Permanente, front desk staff can actually check and book for preventive screening. Everyone can help in QI. All these point to the softer side of good quality improvement. That when we look at the science of innovation, it's less about big cognitive leaps and more about agility and small incremental steps that build on the ideas of others and engage our own genuine curiosity regarding what motivates and inhibits the individual and system's path to change. The main point is, start. Find something you can improve and get going. Look, it's hard to summarize improvement and not get into bumper sticker territory, but I would advise not to let what you can't do stop you from what you can do. It's time to entertain complexity, but focus on simplicity, asking yourself, what can I do by next Tuesday? Have a meaningful needle and test some changes to start moving that needle towards an important goal. Hope this helps, and thanks.
Okay, what'd y'all think?
Very good.
Did you like that?
Yes.
Oh, good. Good.
Yes,
I'm
a
glad to
lot.
hear it
Mhm.
because, you know, I'm a nerd. I like this kind of stuff.
Well, I'm with you. I felt like the first time we jumped into PDSA, I was right there with you. It was like, ah, and you had a short window to absorb all of that and get moving. So I loved his presentation. Very,
Well,
very
good.
good.
We'll be sending you these slides so you can have the link in case you want to share it with anybody. Is there anything else anybody else wanted to say? Okay, let me go ahead and get back over here.
There's a few comments in the chat. Julie says it's a good video, and
You like the voice, the pictures, and understanding the different reactions to CQI. Yeah, I agree about the different reactions. I think that's, and you probably see this with not just with the families you serve, but also the people who are implementing your PDSAs, that it can sometimes feel like, oh no, not another thing on my plate. But if we can get buy-in, then that makes it more of a team effort and sharing a load.
I think
Okay.
one of the client-centered principles in C1 rings clear to that. Only a small change is necessary.
Oh yeah, that's
And
very good.
MI, I mean, he referenced both things that we use in our work, so, and recognize.
Now, I didn't know what MI stood for. What did that stand for?
Motivational interviewing.
Oh, okay. Thank you. Are all of you familiar with motivational interviewing? Or is it just the C1 programs? Is that something that all of you is that something you do regularly in your work?
Yes. We do it, yeah.
Okay. All right, cool. I learned something today. All right, let me see.
Lisa,
Yes.
just FYI, if you're interested, you can always come. We have every twice a year, we have motivational interviewing as a training. You can always attend if you're interested.
I might do that. Just keep me posted. I might be interested in joining you.
I'll send you the calendar.
Thank you. All right, so let me start this again. And swap the two. There you go. Can you see that presentation?
Yes.
Okay, thank you. So let's say my overall goal is to be healthy. So I recently bought a new Fitbit to monitor my health. So I'm healthy now, right? Well, I'm not unhealthy, but that's not going far enough. To be healthy requires many things to happen. That's the overall goal, kind of like we have the overall goal of improving developmental monitoring and promotion. That's a big goal. So I could start at just my very own informal plan, do, study, act cycle with my Fitbit and choose an aspect of something that is a primary driver of good health. So for instance, I could choose a SMART aim of increase the amount of sleep I'm getting by some percentage. Now I actually have pretty good sleep, but this is an easier thing to talk about than to say, I think I need to lose weight. And so so my plan, let's say that what I plan to do is to wear my Fitbit 24 hours a day and let it record data about my sleep. So my question is, how am I going to know if having that recording does something like increase my awareness of the need for consistent sleep? How am I going to know if I've reached that goal? How am I going to know how well my process went? This is where we get into the difference between a process and a process measure, an outcome and an outcome measure. So to measure something, we need to come up basically with something that'll give us data to analyze. So my outcomes could be these three things. These are things that get recorded automatically by my Fitbit. It'll record, I don't know how it does it, but it records the number of hours I get of sleep in the night, the number of times I wake up, and the number of times I'm restless in the night. So all of those can contribute to quality sleep. If I'm waking up a lot, then I can't be having very good quality sleep. If I'm restless, 50 times a night, there's something going on that's interfering with me getting quality of sleep. If I'm not sleeping enough, that itself is going to affect my quality of sleep. So I have to operationally come up with a specific definition for what does it mean to increase the amount of sleep. Am I focusing just on the number of hours of sleep? So to know if my sleep hours increase, I have to start somewhere and measure at least one more time. So you've seen this with your other PDSAs. You had lots of programs have had studies with you have some kind of pretest or first occasion of measurement, and then we measure over time and we can see the change, because if you just measure once, you can't see change. So what did we've been using the term SMART aim, and just to remind everybody and to share this with those who may not remember exactly what SMART aim means. We want our aim to be specific. Instead of having my general goal of improve my health, I'm going to have it specific, increase the number of hours of sleep by X%. Measurable, I can't say that, improving my health, that statement really isn't measurable because it depends on what you're looking at. So we have to come up with something that we can measure. And how we measure it has to be specific as well. Because even a concept like sleep, as we saw, if we're talking about the quality of sleep, that could mean different things. And so we have to come up with something that's measurable, not something like, did I have an interesting dream that night? Well, maybe I did, maybe I didn't, but I might not remember it. And so that's not really something measurable that we're certain is linked to quality of sleep. Something achievable, that big goal of improving my health, that may be achievable if I make several changes. But for our aim, we want to be able to get there. If I said increase the number of hours I sleep by 50%, that would be kind of crazy. That would probably start cutting into my work day. And I don't think David Bard would like to pay me to be sleeping on the job. So we have to make it something we could actually accomplish. Relevant. If I am interested in improving the quality of my sleep, I could keep a diary of what I eat for dinner every night, but that's not relevant. It may in some way affect if I'm eating too late in the day or if I'm eating really spicy food. I can imagine it could affect sleep, but that's not really relevant. We want our measure to end up being something that'll be associated with the quality of sleep. And timely, we want these PDSA cycles, and we design it in our learning collaboratives and our learning sessions. The PDSA cycles are within a defined period of time so that it's not like someday we're going to get to where I'm increasing the number of hours of sleep by a certain amount, but I'm choosing a date. By this date, I'd like to have improved it. So process measures, here are some things that we could measure. For process, I could keep track of the number of nights that I actually wear the Fitbit. But I also have to start and stop the app on my phone for recording the data. I have to get onto the app on my phone and say, start sleep. And so it's going to know I'm awake for a while, but the device then will start to record, okay, the potential for number of hours in bed and the number of hours of sleep is starting now. And then when I get up in the morning, I have to remember to stop, to say I'm awake on the app. One time I forgot to do that, and I looked at it later in the day and it said that I had been asleep for 23 and a half hours. Well, so much for that day. I also may be interested in keeping track of the number of nights I'm in bed before midnight, or 11 o'clock or some chosen time, because that may be something about the process that I want to make sure I do as part of supporting my goal to improve the number of hours of sleep. Now, what could interfere with that? Well, here's this old Scottish poet, Robert Burns, the best laid plans of mice and men gang aft a gley. That's my great Scottish accent. But, doesn't it make you wonder, what are those mice planning? I mean, what are they going to take over the universe or something? Okay. Again, goofy statistician sense of humor. So disruptors, what could disrupt my ability to reach my goal? Well, if I'm sitting there watching TikTok, after I get in bed for 2 hours, that's keeping me awake. So the amount of time I'm going to measure that use of TikTok as a potential disruptor by having some way of measuring the amount of screen time after 11 p.m. So if I'm planning to get it to bed by 11 o'clock, am I actually going to get to bed by that time? Number of occasions of disrupted sleep. That's something that the Fitbit will record. That's being disturbed and restless in my sleeping is a disruptor. And I can measure that disruption by what the Fitbit records as the number of times that I was restless. And so then it becomes an objective measure. Let me pause here and see if there's any questions or any comments so far.
So I'm glad that you're doing this, Lisa, because I have new staff that maybe didn't go through this process. So going through this is very helpful. And I love your example.
Okay, good. Thank you. I appreciate you saying that. Okay, so here's the change theory diagram. You notice over here is improved sleep quality. That's what I want to influence because that is a primary driver for my ultimate goal beyond this off to the right on the screen, the ultimate goal of improving my health. So that I'm treating as a key driver to improving my health. And my SMART aim is going to be increase the number of hours of sleep by whatever percentage that I've chosen. And so then what's my process? Here are the things I'm going to do. I'm going to wear the Fitbit 24 hours a day to record data. And I'm going to each night record if I wore the Fitbit and got to bed by 11 or by midnight, whatever my chosen time is. Now, what can disrupt that? Sleeping fitfully. And I'm measuring disrupted sleep as the number of occasions of, and that could be number of occasions that my Fitbit recorded that I was restless. And it could be the number of times I woke up, because that's a separate thing that the Fitbit records. And then another disruptor is the amount of screen time after 11 o'clock. And I'd have to figure out how to record that. So what happens next? I set my plan in motion. This is the do part of the plan, do, study, act cycle. And so I'll make notes about how it goes over the next few months, whatever the time period is that I want to achieve the change or improvement in my sleep. Study. This is when I analyze the data. And this is where everybody else goes, and I'm going, ooh, data, give it to me. I get to graph it. I get to play with it. So I'll start with my outcome. Well, was I measuring it? I was measuring the number of hours of sleep. And I can ask, did it, on average, did it increase? The average nightly number of hours of sleep, did it increase from the first week to the last week? And I could graph the data across weeks to see a trend. My process, I can graph and compute a weekly percentage of nights that I wore the Fitbit. If I'm wearing it 6 out of 7 nights, with the 7th night being for charging the Fitbit, that may be showing good adherence to my process. Another process measure, I wanted to make sure I was in bed before midnight or before 11, whatever I choose to be my time, and compute the percentage of nights I was in bed by that time. Because if I'm staying up past midnight every night, I'm not adhering to my plan. So what the study part is showing is that I failed myself on my plan. And so it wasn't that there was anything wrong with the Fitbit, it's that I self-sabotaged myself by not getting into bed by my chosen time. My disruptors, well, we need the data for those disruptors. Number of minutes of screen time after 11 o'clock. I can compute that. I can graph that. I can compare from the beginning to the end whether I reduced or if I increased, because if I increase the number of minutes of screen time, that's something that's going to also mess up with the process. I may be faithfully going to bed by my chosen time and then staying up till 2 in the morning watching TikTok. That's going to keep my plan from being effective. So that's why we have to measure disruptors, and we try to predict what's going to interfere with the quality of this process we're trying to implement. And then I can compute and graph the weekly average number of occasions of disrupted sleep. So if I'm just not sleeping well, if I have a lot of stress, if I have a family member who's sick and I'm worried about them and I'm waking up several times in the night, or I'm just tossing and turning a lot, then I may see that on this graph. And that could explain if I don't reach my goal of improving the number of hours of sleep. So then the decision is act. That's the last step. What am I going to conclude? Am I going to adopt this process and continue wearing the Fitbit nightly and getting to bed before my chosen time? Am I going to adapt the plan? Maybe I've noticed that on the weekends, I tend not to get to bed as early. Maybe I'm out partying. Maybe I'm going forward. Now, before we go into this, questions, comments, observations? Okay. Now, when we're looking at our big ideas for child development, this is our overall aim: increase developmental monitoring and promotion. That's been our big idea. That's what we're trying to accomplish, improving the developmental monitoring and promotion. There are certain things that may drive changes in developmental monitoring and promotion. Some of these primary drivers could be categorized in one of these areas. It could be in developmental and behavioral screening, as some of you did for your previous PDSA, increasing workforce training on child development. That's something that Oklahoma City C1 did. Or increased family involvement with child development, which is what some of you did with the positive parenting activities. And then that can be broken down in what is affecting improving developmental and behavioral screening. Well, maybe there needs to be a standardized process. And one of the programs talked about having a site for discussions with family about the results of developmental behavioral screening as part of trying to improve the action on referrals. So these can continue to break down to these more granular ideas, like working with families to complete those Learn the Signs developmental checklist, or use the positive promotion milestones tracker app, and so forth. So you'll see we've seen this in meetings like this one. So, and sometimes you may see something that is in primary driver down to the change. It could apply to some other drivers. This isn't set in stone. It gives you some ideas of where you want to go next with your next PDSA. So we're going to do the breakout rooms next. And as David was saying, is he in the meeting?
Yes, sorry, struggling to find mute. I'm here.
Okay, there are the programs that are going to hear about the parenting app, PCT, SARE, and DA. Going to start off with going to hear from David about that, and then you'll go to your breakout room to complete your PDSA, and your analysts are with you. The C1 programs.
Question for LCBA is going to be Safe Care and BAT or just Safe Care?
Patty, I think that's up to you. If why don't you bring them both, actually? And you're not fully committed to using it for either one of those programs, and we'll talk about that in just a second.
Okay. All righty.
Okay, thank you. Other questions about that? Okay. Now, both of the C1 programs, you'll be working with Xiaolan in the next cycle, but she can only be in one place at once. And so I will join Oklahoma City C1 in your breakout room. I know you already have a good idea of what you want to do next. And Xiaolan will go into the Tulsa C1 program, your breakout room. And let me see what time it's. How do I do this? We're right on time. We're going to work on the PDSA until 3 o'clock, and then we'll have a break from 3 to 3:15. And so we'll go ahead and go into the breakout rooms if Lisa Tunley has those ready. And you can just choose.
I also, oh, did somebody else open them? I think somebody else already opened them.
Okay, yeah, you'll see an icon for breakout rooms. So you can click on that. And no, we don't have names on the rooms. That's the problem.
Oh, I did put names on them. I don't know what happened to the names. What happened?
I don't know.
Let me rename them because I did have names on there. Now they're not on there.
That's crazy.
Yeah. I think if you stop recording or anything like that, sometimes it changes.
Oh, okay. Well, you can go ahead and stop the recording for now if you want.
Space.
I'm gonna,
You're
Ariana,
muted.
I think you're on mute, but she was having trouble with her Zoom earlier.
Okay,
You got it.
can you hear me?
Yes.
Okay, let's go. Okay. 80% of the children with an ASQ on their cutoff are referred to services, and then 50% of the children are receiving the appropriated services.
80% who are at risk are going to get referred. Is that what I heard?
Mm-hmm.
And then 50% of those that get referred are going to receive services. Okay. I think that's a very reasonable, right? With our smart aims, we want to be realistic with it. We've seen what our numbers look like right now. A lot of that, we hope, is artifact of how we're documenting or capturing the documentation. But I like it. And I'm glad to see another project focused on that, especially given our transition for the next learning collaborative, working with Unite Us, and where that will be the centerpiece of all of our change ideas. Great, thank you. All right, who is up next on my random? Patty, you want to tell us about what the LCDA programs are going to work
Yeah,
on?
this starting August 15, PAT and Safe Care programs will recruit 5 participants to test the Positive Parent app and get them engaged.
Excellent. Thank you again for doing that. Excited to see where that one leads. Kathy, you're next.
I'm gonna hand it to Dava. She's got the
Oh, okay, Dave, I'm sorry.
form.
Okay.
Thanks, Dava.
So ours was to increase nurse home visitor self-reported level of knowledge by 10% using pre and post survey with monthly trainings.
I missed the first part of that. Did you say providers or clients?
Nurse home visitors.
Nurse home visitors. Okay,
Mhm.
great. Another one focused on workforce. I like it. Okay.
We can go with C1.
D1.
C1 told OKC.
Sally, are you out there?
Yeah, I'm out here.
You're not on my screen yet. There you are. Okay.
This is Sally.
You're up.
Ours was to increase the nurse home visitors' knowledge and comfort level with atypical development, child development by 10%.
Okay, great. 2 of them focus on the workforce. Am I missing any other programs you were on today? Oh, I know I'm missing.
Frontline and
PCCT. How about PCCT? Kelsey?
We are also going to be a part of that 10 to 15 clients and getting them engaged in the Positive Parenting app.
Yes, so for those who are not participating in that, there'll be 2 phases essentially and 2 PSAs for the groups who are working with us on the parenting app. We're doing a beta testing phase that'll start next month, and we're hoping that each program can enroll up to 3 clients for that. And then starting in October, there'll be a separate PDSA that's nearly identical, and we're looking for more clients from each program as we do a formal evaluation of the effectiveness of that particular intervention. Thank you, Kelsey. Okay, who is the other one, Lisa? The program that
I don't know if Deidre's on here, but Frontline, somebody from Frontline.
I'm still here.
Okay.
reworking.
Ours is going to be after delivering the ASQ materials, the caregiver's understanding of the importance of ASQs will increase by 10%.
The caregiver's understanding of the ASQ importance. Okay, that's a unique one out of the box I hadn't thought of yet. How will you measure that? Forgive me, I'm gonna have you elaborate a little bit.
We're going to measure it by the, we have questions, the little survey questions, and after they complete a ASQ, then they're going to answer those questions, and those questions are like their understanding of the results. So that's how we're going to measure it, by the survey, basically.
I imagine the providers already have, the PEs already have a script that they loosely follow as they introduce the ASQ and as they run through the results. Is that accurate?
That is correct.
Okay, and so after we've gone through those scripts, we want to know how much of that resonated with the client.
Correct.
Okay, interesting. Okay, I like it. All right, did I hit everybody? Any programs unspoken for, Father Smarting? Lisa, I think that rounds us off then. And are we ready to dismiss this crowd? I want to say thank you. And again, I really look forward to this day. I'm celebrating with you, I hope, your successes and the PDSAs you presented this morning. Kind of feels like we've been here for 2 days, right? We've had quite a bit accomplished here. The whole morning review of what you did with phase 2, and now the afternoon introduction of PPAC and some of the work that's ahead for evaluation research and CQI, where they're going to be more involved, and parents in general will be more involved. And then, of course, your development of this 3rd and final phase of our developmental promotion and monitoring CQI. So thank you. Thanks for your sustained interest. As always, your attention to detail and your enthusiasm to see these projects through from beginning to end. And kudos on the successes you shared with us this morning.
All right. Thanks, everybody. We'll be in touch.
Okay.
Bye.
Bye-bye.
Thanks, everyone.